So now we start with the little bit that we had not been able to cover in the previous video, which was sclera and limbus. So basically I was about to cover the entirety of the outermost layer in the previous video, which was cornea, sclera and limbus. Together they make up the outermost layer of the eye. And I couldn't cover it in the previous video, but in this video we will be covering sclera and limbus. So let's start with sclera. So what exactly was sclera? So very quickly, we already know if this was the eye, this white portion on both sides that we have, this is the sclera. Okay, so basically in the mirror, whatever white you see in your eye, that is the sclera. Now, does that mean that the white portion of your eye is only present anteriorly? Only the part that you can see is the white portion, or whether or not the white portion also extends posteriorly? Well, the answer is sclera, which is the white portion, extends posteriorly as well, to the extent that it covers 5/6. It covers the outer 5/6 of the eye. So what is the 1/6 of the eye that it does not cover? Very simple, it does not cover the cornea. We have already seen what cornea is over here. Let's go back to some images over here. Okay, see, this white portion was the sclera, and cornea is basically transparent. Limbus is the junction between sclera and cornea. So the anterior 1/6 of the eye, which we need it to be transparent so that light rays can actually enter and form vision within our eye, that part is not sclera. That part is not covered by the sclera. Why not? Because we already know this, but still we'll be writing this down. Sclera is opaque. It is a whitish, opaque, fibrous and protective covering. So its basic function is what? It is protective in function. It is fibrous, protective. We have already seen to these facts. The most common type of collagen is type 1 collagen within the sclera. We already know this fact as well. And we also know that the most common glycosaminoglycan present in the sclera is keratin sulfate. These are all one-liners that we should be acclimatized to. So these are some basic facts about the sclera. Now another thing about sclera that we have already talked in the previous video as well, which pertains to the arrangement of the collagen fibers. Now why are they opaque? Why is it whitish in color? Why is it opaque? Because the collagen fibers in the sclera, they are irregularly arranged. They are irregularly arranged. Now, if you have seen my previous video on cornea, you will know that cornea also has collagen fibers, right? But within the cornea, the collagen fibers are, how are they present? Yes, they are present in a regular manner. They are laid down in a regular, patterned manner, in such a way, in such a distance from each other that it is lesser than half of the wavelength of the light traveling through it, which means there is destructive interference of light, and thus there is no backscattering. Okay, there is no scattering of light present. Anyways, we have already seen all of this in cornea. In sclera, on the other hand, it is not regular but rather irregularly arranged, and hence, unlike cornea, the sclera is not transparent but rather opaque. And we need an opaque structure covering most of the eye. Why? We cannot have our entire eye be the window through which light comes in. If the aperture through which light comes in is too wide, then there will be multiple images being formed, too much diffraction, like too many interferences. Light rays will interact with each other. There will be destructive interference, constructive interference, and all of that will happen, right? So basically what we need is, we need to control, or we need to have a controlled aperture through which light can enter. That is why cornea is transparent, and even through the entirety of cornea, light does not travel, right? So we have already seen to this as well. Let's go back to that basic picture of the eye over here. So basically, you can see that this entire portion is cornea. Right. Obviously, you cannot see the cornea. The cornea is transparent. What you can see is the iris over here. The blue colored portion is the iris, which is within the middle portion of the eye, the middle layer of the eye. Within the iris is the blue portion. Then what is the black portion over here? This entire black portion, what is this? This black portion is basically the space in between the two, or not the two, but rather the space in between the iris. That is the pupil. So basically, if I remove this part, this entire black portion is basically pupil. This is the pupil. So what is the pupil? Pupil is nothing but the aperture through which light can travel through. And it is very simple. In that image that we had drawn, let's go back to that. This is the cut section of the eye. This is the transverse section of the eye that we are seeing here, and we are seeing it from above. So basically this is the cornea over here, right? And this over here is the iris, right? We can see to that. Now in between the iris, this space that is present, this is the pupil. As simple as that. Pupil is basically the window or the aperture through which the light rays can travel through. You can also think of an aperture through which light rays travel through in a lens, in a camera lens. You can also think of that analogy, right? So basically our eyes are what? Camera lenses, right? Or rather our camera lenses are, they function, or they are fashioned in the principle that human eyes work. That is basically the more apt thing to say. Anyways, let's go back. So sclera, we were talking about the sclera. We said that it is opaque, and that is basically it. Now, it is opaque and it is fibrous and protective. So basically it has a thickness. It is irregularly arranged collagen fibers, which means that the thickness within the sclera will also vary. So the thickness of the sclera varies. At some point of the sclera will be the thickest. At some point it will be the thinnest. Let's jot down where those points are. So the thickest point where sclera is basically the thickest is around the optic nerve. Optic nerve. Let's very quickly draw that. So remember, I can also go back to okay, no, let's draw it. Actually, it will be much better if we draw it. So remember, basically this is the sagittal section. Okay, see, this was over here the cornea. We are basically seeing the eye from the sagittal section, that we have cut it in half, and then we are seeing it from the side. So basically this is the anterior part, this is the posterior part. So this entire white portion that I have drawn is the sclera. So sclera is covering this entire white thing except this part. This is cornea. Okay, now basically this over here, these two lines that I have joined, this is the junction between the cornea and the sclera, and hence this will be named limbus, which we will talk about subsequently in this video. Around the optic nerve, that is over here, sclera is the thickest. It is the thickest. So basically if I have to draw, I will draw sclera the thickest over here. Okay, how much is it? Basically it is approximately equal to 1 millimeters. How much is the thickness? 1 millimeters approximately. Okay, now how much is the scleral thickness in the limbal portion? In the limbal, there is a sclerocorneal junction or limbus. What is the thickness of the sclera there? At the limbus, it is neither the thinnest nor the thickest, but rather an intermediate kind of value, that is approximately 0.83 millimeters. Then where is sclera the thinnest? Well, to know where sclera is the thinnest, we need to know another structure. That is, I have talked about it briefly. These are, remember in my previous video I had talked about extraocular muscles. So basically the extraocular muscles, which are the recti muscles, they insert into the sclera. What is the need for the extraocular muscles, you might ask? Well, it is very simple. You can move your eyeballs according to your own will. That is present, or rather that is possible only because of the extraocular muscles. If I ask you to see towards your left without moving your neck, you can do that. You can move your eyes towards the left. You can move your eyes towards the right, up, above, down, below. You can do all of that. Why? Because of the extra. Extra means outside. Ocular means eye. So outside the eye, these muscles are present. The recti muscles, we'll talk about them in a great lot of detail. They insert into the sclera. So around the part where they insert into the sclera, Sclera is basically the thinnest. The thinnest. So it is the thinnest at the insertion of recti. Let me just move this. Recti muscles. Okay. How much is the thickness over here? It is basically 0.3 millimeters. 0.3 millimeters. So we have learnt of three values over here. 1 millimeters where it is the thickest around the optic nerve, limbus where it is an intermediate 0.83 millimeters, and thinnest where the recti muscles insert into the sclera, that is approximately 0.3 millimeters. So basically what we are talking about is the fact that even though sclera covers the entirety of the eyeball, at least posteriorly it covers the entirety, anteriorly 1/6 anteriorly it does not cover, right, which is the cornea. Even though it is covering so extensively, its thickness is varying at different points. Done. Now obviously since it's a thick layer, since it's a thick covering, it will have different layers. So let's talk about the different layers of our dear favorite sclera in this slide. Now, what are the three layers of the sclera? First, episclera. Remember when we were talking about the layers of the cornea, we had said that the outermost covering of, or rather the outermost layer of the cornea is epithelium. So epi means outside. So the outer sclera, outermost layer of sclera is called episclera. As simple as that. Okay. Then what is the second layer? It is called sclera proper. Sclera proper. What is the third layer? Third layer is lamina fusca. This is the innermost layer. So basically we are going from outermost to innermost. Okay, outermost to innermost, episclera, sclera proper, lamina fusca. Let's learn 2 or 3 facts about each of these layers. Okay, episclera is the outermost part, and this is the layer that we will be talking about in the most detail because of 2 reasons. Actually, 1 reason. The reason is the pathologies of sclera are related to this layer, episclera. Okay, anyways, so episclera is the outermost layer, and if you have ever looked at your eyes in the mirror carefully, which we all have, obviously, you will obviously have seen small tiny blood vessels in the white portion, right? We all have those small tiny blood vessels in the whitish portion of our eye, which is the sclera as we know now. So that means that the sclera has some blood vessels running through it. That layer of the sclera which supports the blood vessels within the sclera is the episclera. So it is the densely vascular layer. The densely vascular layer of sclera. Now, the way that the blood vessels in the episclera are laid down, they are laid down in 2 plexuses, 2 layers. What are they? It is basically laid down as a superficial blood vessel layer and a deeper blood vessel layer. So basically there are 2 layers to this, to the blood vessels that are present in the episclera. The first fact that you know about episclera is the fact that it is a densely vascular layer. Okay, got that? Embed that within your mind first. Second point is the fact that these blood vessels that are present within the episclera are laid down in 2 layers, the superficial blood vessels and the deeper blood vessels. Very, very important to know the arrangement of the blood vessels in this case, because the subsequent pathologies that we are going to be exploring within the sclera are related to the blood vessels and their arrangement. Okay. So for now, just know this. The second fact that we can very clearly see is the fact that deeper layer of the vascular layer that is laid down within the episclera is what? It is closer to sclera proper. Obviously. Now, the fact about sclera proper is that episclera has blood vessels, sclera proper does not. It is avascular. Very, very important facts we have laid down in this slide. Now, based on the arrangement of blood vessels and their arrangement to each other, the way that they are laid down. Now let's talk about two very important pathologies of the sclera. What are they? Episcleritis and scleritis. Let's write them down first. See, what are the scleral pathologies that we will be talking about? Episcleritis and scleritis. I have intentionally used red and blue to denote episcleritis and scleritis respectively, as we will explore subsequently. So what is episcleritis? First of all, the thing that we need to realize here is both these terms have itis in their names. Itis means inflammation. This much we obviously know by now. So what is episcleritis and what is scleritis? Both have something to do with inflammation, and inflammation means something related to cells, something related to blood vessels, something related to that. We have already talked about two layers of blood vessels within the sclera. So obviously episcleritis and scleritis have everything to do with those blood vessels. What is that? Episcleritis is basically inflammation of the superficial episcleral plexus. Episcleral plexus, we have already talked about that. Episclera has the superficial layer of blood vessels. Their inflammation is episcleritis. Does that mean that scleritis is the inflammation of the sclera proper? That is not possible. As we have already mentioned or established, sclera proper is avascular. So how can an avascular layer be inflamed? It isn't. Actually, scleritis is a misnomer. Scleritis is basically inflammation of the other blood vessels. What is the remaining blood vessel? The deeper layer. So the deeper episcleral plexus itself. So basically this is also the inflammation of episcleral blood vessels, but the deeper layer. Now remember, I had mentioned the fact that deeper layer of the episcleral plexus is closer to the sclera proper. Hence, their inflammation is a misnomer kind of. It has been mistakenly given the name of scleritis, as if it is a sclera proper which is inflamed, but it isn't. It is the episclera in both instances which is inflamed. Done? Done. So episclera, or rather episcleritis, what is that? Scleritis, what is that? We have at least laid down the basic definitions of that. Okay? Okay. Now that we have mentioned their definitions, let's actually explore these two diseases in a little bit more detail. So we can see in both instances we have actually pictures. As you can see, this is the first thing that I would really draw your attention towards. See, episcleritis, it is already seeming as if from the image, I'm obviously now talking about the images in these two cases. Obviously from the image itself, you can kind of see that in episcleritis, that is this one, this picture, it is a reddish hue which is given off. A reddish hue is given off, and it already seems like it is inflammation of the superficial layer, whereas in scleritis, there is also reddish, inflammation, obviously, because inflammation means blood traveling more blood, more congestion, more cells. So obviously reddishness will obviously increase. There is no difference in that. But there is also this very strange, I don't know if I can draw your attention towards this bluish hue. My marker ink is not sticking to that. I don't know, but I hope you can kind of explore, or rather you can see. I'm actually holding my pen over here. So hopefully you can see this bluish or violetish hue. So this is a very, very interesting thing that differentiates episcleritis from scleritis. Scleritis being inflammation of the deeper blood vessels. The deeper blood vessels, that is why, since now this is a very common concept that we have, inflammation of any deeper blood vessel will give off a bluish hinge, whereas a more superficial one will be more reddish, because the deeper structures, venous, superficial more arteries, something like that. Okay, even though in these two cases we won't be going into that kind of a distinction, but it is very, very evident from this picture, at least in scleritis, that there is a violaceous hue, there is a bluish hue, which means some kind of a deeper structure is involved. Okay. Another very interesting fact which helps us in differentiating between episcleritis and scleritis is the fact that episcleritis, being the inflammation of more superficial structures, often has no tenderness associated with it. No tenderness. Whereas scleritis, being the inflammation of much more deeper structures, often has tenderness. Okay, so tenderness is often present, tenderness or pain, but in episcleritis often no tenderness. Okay, now often episcleritis is idiopathic in nature. These are all differentiating points. Often idiopathic. Idiopathic means the cause is unknown. Unknown cause. It is not associated with any other infection. It is often an isolated infection, or the cause is most often not known. However, scleritis is a much more complicated, or rather much more grim ordeal. Why? Because scleritis is not just an infection in the eye. Often scleritis is actually associated with much more serious systemic diseases. What systemic diseases we are talking about? We will talk about that in just a moment. Okay, so often scleritis is associated with some other pretty grim systemic illness. Episcleritis, on the other hand, is mostly idiopathic. Now, although I have provided two pictures over here, but in clinical practice, from what I have been told, I have also never encountered, as of now, as I'm recording this video, I have not encountered episcleritis or scleritis cases in my clinical postings as of now. But from what I have been said, it is often not as black and white as this picture would have you think. So episcleritis, reddish hue, scleritis, violetish or bluish kind of a tinge you will get. Oftentimes, scleritis is also reddish. So it is very, very difficult to differentiate on a naked eye examination the differences between episcleritis and scleritis. We cannot. And differentiating between episcleritis and scleritis is often very important. Why? Because of the very simple reason that episcleritis is a simple inflammation, whereas scleritis is often associated with systemic diseases. So we need to be more careful. We need to have more systemic checkups for the patient, right? To detect other illnesses within the patient. Anyways, so bottom line is we need to differentiate between them on a more surer basis. How do we do that? Well, as it so appears, there is a test to do that. What is that? The test is nothing but the vasoconstrictor test. The vasoconstrictor test. So what are we using here? As the name suggests, we are using a vasoconstrictor. Vasoconstrictor eye drop. What is that? 2.5% phenylephrine. 2.5% phenylephrine eye drops are used. What does phenylephrine do? It is a vasoconstrictor. What is this entire pathology? It is inflammation, which means there is vasodilatation, more blood coming through. That is why the reddish, violetish, whatever hue, right? So now we are using a vasoconstrictor. So if we use a local vasoconstrictor, what will happen? The redness, that should what? Disappear, right? So as we can see in this picture, the redness has disappeared. This is before and this is after. Right, like those fairness cream commercial breaks, ads, before and after. Anyways, but this before and after, this vasoconstrictor test, this will only be positive for episcleritis. Only positive for episcleritis, which means that this redness disappears only in episcleritis, not in scleritis. So even after application of 2.5% phenylephrine drops and we wait, the redness will not go away in case of scleritis. Why? Because of the simple reason that we are applying eye drops topically, which means they will not penetrate the deeper layers. And scleritis is basically inflammation or pathology of the deeper layers of the eye, right? So the deeper blood vessels, the deeper plexus of episclera. So basically the redness will not vanish, whereas in case of episcleritis the redness will readily vanish away. That is blanching rather, right? Blanching is the term that we use, the scientific term for this redness, whatever. So this blanching, the redness, not the redness itself, the redness disappearing is known as blanching. So basically blanching is what? Blanching. Let me just, this is called blanching. What does blanching mean? If you take your finger, any of your fingers, and you apply pressure on it, what will you see? You will see that it becomes yellowish, right, under pressure. Why is that? Because you are basically applying pressure and you are driving all the blood from that tip of the finger away. So that appearance is called a blanched appearance. This is basically what is happening, right? The redness is going away. In case of scleritis, the redness will not go away. So blanching is negative. So this is a very sure short way in which we can differentiate between episcleritis and scleritis. Now let's talk a little in a little detail the types of scleritis. Basically, scleritis can be differentiated or rather divided into two parts: non-necrotizing and necrotizing. Necrotizing scleritis and non-necrotizing scleritis. Necrosis, we obviously know, it is the end result of a lot of inflammation. If a lot of inflammation goes on and nothing is done to stop it, oftentimes what might happen is that body part might end up getting necrosed, gangrened. So necrotizing often means that there is extensive damage to tissue. So scleritis can be non-necrotizing or it can be necrotizing. Now within necrotizing, again, there is two parts of it. Necrotizing scleritis can be associated with inflammation. It can be not associated with inflammation, so without inflammation. Now this is a very confusing thing. Scleritis itself means inflammation. Then how can a kind of or a type of scleritis be without inflammation? That is a question you might be having right now. Very simple. When we say without inflammation, in this case, it means that there are no signs of inflammation present. There are no signs of inflammation present. No signs of inflammation. But necrosis is going on. So there is necrosis, but no signs of inflammation. Okay. So basically what will happen, since there is no inflammation, there will be, or no signs of inflammation. What were the signs of inflammation? We know dolor, then tumor, then there is rubor, right? So there is basically what? Temperature, there is redness, there is calor, there is heat, all of that, right? So obviously heat is something we cannot expect within the eyes. We can expect it in a local area. In the skin, if your skin gets inflamed, a part of your skin gets inflamed, that part becomes, red hot tender. We often say the swelling becomes red hot tender, it is inflamed. But in the eyes, we cannot expect eyes to be warm or something like that, right? So basically we are omitting the heat part, but it can become red, it can be associated with pain, all of that is still present. We are saying no signs of inflammation, which means there is no pain. There is no congestion, which means there is hardly any redness. The redness is very non-specific. It is not very associated with an inflammation. So you might not be able to really specify it as a kind of inflammation. Why? Because we are talking about a kind of scleritis which is associated without inflammation, as if there are no signs of inflammation. There is inflammation, obviously, because scleritis, right? But the inflammation is mild. There is more necrosis going on. This entire thing that I've described over here, if you're getting confused, I'll explain it once more. See, we are talking about the types of scleritis. It can be non-necrotizing, it can be necrotizing. Necrotizing scleritis can be associated with inflammation, can be not associated with any inflammation. When we are talking about the necrotizing scleritis without inflammation, we are talking about a very specific kind of scleritis, which is not associated with any pain. There is no congestion. There are no signs of inflammation. There is only necrosis going on. This very special kind of necrotizing scleritis has been given a name called Scleromalacia perforans. Scleromalacia perforans. Sclero means sclera, malacia means soft, and perforans means perforation. So oftentimes the sclera becomes so soft from the necrosis that oftentimes there can be a perforation in the sclera. As you can see, there is this violetish hue over here. So we know that this is some form of a scleritis. Some form of a scleritis is going on, but the redness is not that much. So, however, if you see, there is not much redness present. That is, see all this part of the sclera, basically it is non-inflamed. Not much redness, but there is necrosis going on. There is necrosis going on, and this is what we say to be Scleromalacia perforans. Okay, only the bluish hue is present over here. Reddishness, you might say it is inflamed, but those are more the conjunctiva is probably inflamed in this case. It is not the sclera that is that much inflamed. The sclera proper or the episclera itself is not that inflamed over here. Rather, there is more bluishness being given off. So it is more bluish than it is reddish. That is a very apt way of describing Scleromalacia perforans, and I've already explained to you the literal meaning of the Scleromalacia term. Now, a very, very important thing, and this is what I was actually holding off when I said systemic illnesses. Scleromalacia perforans, which is basically a type of scleritis, is most associated with a very common, or rather very dreaded systemic illness, which is rheumatoid arthritis. Okay, when we will talk about rheumatoid arthritis in our medicine videos, we will explore this point further. Okay, so rheumatoid arthritis, so Scleromalacia perforans is related. So any patient with rheumatoid arthritis that you see, automatically you will look into their eyes and you will try to find signs of Scleromalacia perforans. And we will later, when we talk about rheumatoid arthritis, we will see that it is more common, like most autoimmune diseases, in middle-aged women. Okay, so basically in middle-aged women, Scleromalacia perforans is more common. Okay, so this is a very, very important slide, and this is a very, very important disease as such. That ends our discussion on the sclera. Okay, so we have talked about the scleral anatomy, the different layers of the sclera, the two different pathologies of sclera, and we have talked about them in detail. Now, let's end our outermost layer anatomy of the eye with small discussion on limbus. So basically it is very simple. We already know what the limbus is. If you don't, I'll draw it again here for you. This over here is sclera. This over here is the cornea. Obviously not that blue part. The blue part is the iris. Cornea is basically transparent, so you won't be able to see it as such. But basically cornea is the transparent covering over the anterior 1/6 of the eye. Okay. Now, the junction of sclera and cornea, which is this over here, part that I'm dotting, this entire part, this is the limbus. As simple as that. Done. So basically that is limbus. So why is the limbus important? I had already talked about this. Why have we given the sclerocorneal junction a different name? We don't give every structure in our body a name. We don't say the tip of my fingertip, my fingertips have a different name. The ends of my hair do not have a different name. The ends of my nail do not have a different name. Why does the sclerocorneal junction have a different name? Because it has some kind of a function. To understand what its function is, we have to understand what is present within the limbus. Basically, limbus contains stem cells. What are stem cells? We might already know this from our basic biology knowledge, but basically stem cells are pluripotent pluripotent cells. What does pluripotent mean? Pluripotency is the ability of a cell or a structure to differentiate into any other structure, which means that if there is this one cell, it is pluripotent stem cell. This cell can become a cell of the eye. This cell can become a cell of the skin. This cell can become a nerve cell. This cell can become a cell of a muscle, a bone, anything. So it can form any structure within the body. That is the definition of pluripotency. Pluripotent, or rather stem cell definition, is not defined rather as the ability to regenerate. No, obviously not. A lot of structures in our body, a lot of cells in our body, a lot of tissues in our body have regeneration capacity. That does not mean that they are stem cells. Stem cells means if I am a stem cell, I can become literally anything. Anything. For example, if I was to go back into my past, into my class 12 boards I have already given, and now I am to choose my path. So I could have become a doctor, I could have become an engineer, I could have become a businessman, an athlete, anything I could have become. But now that I have studied medical sciences, I have kind of bound to become a doctor. So basically I am no longer a stem cell, but I used to be a stem cell. Okay, that is basically, so I'm just, exploring, or rather explaining in detail what stem cells are. I hope you understand what stem cell means. Limbus, this junction between sclera and cornea, has stem cells, which means they have the ability to differentiate. Okay, where exactly are the stem cells present? They are present actually within the epithelium, in the limbus itself, in the epithelium, in specialized areas called palisades of Vogt. Palisades of Vogt. Vogt. Okay, they are present within these specialized areas. So basically, if we were to microscopically see the limbus, we would have seen that the limbus is thrown, or the epithelium in the limbus is thrown into these crypts and folds. So within these crypts, the stem cells are present. These crypts have been given a special name. They are called palisades of Vogt. Okay. Now, another very interesting thing about the limbus itself is that the specific marker, let me go back to red, or rather white, my eyes are starting to hurt. Specific marker for the limbal stem cells, it is basically ABCG2. ABCG2. Okay, this is the limbus stem cell specific marker. However, the universal marker for all stem cells is CD34. CD34. Now, this is something that we will explain, or rather we will talk about in detail in a later video, but there is a pathology related to deficiency of limbal stem cells. Limbal stem cell deficiency leads to very, very important limbal stem cell deficiency leads to a pathology which we will talk about later, called pterygium. Pterygium. Okay, pterygium is basically the overgrowth of the conjunctiva on the cornea, which is like, if this is my eye, we will see that there are these bat-shaped triangular folds of the conjunctiva thrown over the cornea, encroaching over the cornea, leading to loss of vision and a host of other problems. We'll see to this later. Since limbal stem cell deficiency leads to pterygium, so pterygium, how will we deal with that? We will deal with it. We'll talk about it later as well. We'll deal with it by excision. That is, we will excise that ingrowth of the conjunctiva and something called autografting. Autografting, which means we will graft from other parts of the same, from the donor itself, we will take stem cells and we will implant it there, kind of like that. So autografting, how is that a treatment modality for pterygium? To know that, we had to correlate pterygium with limbus anatomy. That is why we have talked about a little bit about pterygium in this video. We'll talk about it in a lot more detail in a separate video, but that is basically limbus. All we have to know about limbus, that is basically the anatomy of sclera and limbus, and that covers, I think, the entirety of the outermost layer of the eye. In the next video, we will start the anatomy of the middle layer called the uvea. We will talk about its different parts, which is the iris, the ciliary body, then the choroid itself, and we will also talk about the accommodation reflex, Horner's syndrome, and all of that we will talk about in our subsequent videos. So I hope that you have found this video to be somewhat useful, helpful, and I hope to see all of you again in my next video. Thank you very much for watching. Hope you have a good day. Thank you.